one of the fields in multiple myeloma that we are investing we are doing more research in is how to when to start treatment in multiple myeloma. And we know, of course, that when a patient has a symptomatic disease, there is no doubt on starting treatment. But the point is, if we have to start with an asymptomatic form, and I think we are all seen or we have in mind that as early as we start treatment is better for the patients. Maybe we have to identify well which are the asymptomatic patients, those patients that do not require treatment for a period of time. But we have changed our mind and say, okay, maybe we have to start earlier and identify which patients would benefit the most from started early treatment. We don't like we don't like to wait for the disease to emerge or disease to progress and to achieve different cytogenetic abnormalities, for instance. Now, the IMWG and other groups, we are all working on that, on trying to identify those patients that would benefit the most from this early treatment. And this is what we are doing. We are now having a lot of biomarkers, such as the MRI with the focal lesions, with the free light chain, the Pence-Jones. We have the 2020, that is the one from IMWG. So we all have to be aware. We can decide which one would benefit for that. But what is important for all the myeloma community is to have this in mind, that in asymptomatic myeloma patients, we used to wait always. Now we have this doubt, or we have to start or not, or we have to wait, or we have to start now treatment. What is the best induction for these patients? I mean, if we decide that the patient has to start treatment and that would benefit from treatment, in my case, I think we should treat with everything. Treat him as an overt myeloma, and with an induction therapy for transplant eligible, with the best one, with quadruplets for probably anti-CD38 plus BRD, if feasible, or VTD, if this is what we have approved, followed with transplantation, consolidation, and maintenance. In an elderly patients that we are not using transplant, maybe a triplet, but also the incorporation of a monoclonal antibody, anti-CD30 monoclonal antibody, is also of great use. So trying to put all the great weapons we have, the great bullets we have, to use them as soon as possible for our patients in multiple myeloma.